Hello, my name's Amanda McEwen, and I am a Worcester State University student, and I am doing my pathophysiology presentation on ALS, amyotrophic lateral sclerosis, which a lot of people know as Lou Gehrig's disease, which was an American baseball player who died of the disease. Um, and the rationale for choosing this disease as the research topic is based on my recent diagnosis of my stepfather with slow progression ALS. The symptoms of his disease were vague and were misdiagnosed for several years, highlighting the need for increased awareness of this condition that currently has no cure. Despite the prevalence of ALS, there is still lack of widespread knowledge of the disease, leading to many individuals suffering worldwide. So I'm going to start by what is amyotrophic lateral sclerosis. ALS is a highly fast-paced neurodegenerative disorder that affects the motor system. This condition is characterized by the dysfunction of both the upper and lower motor neurons, which serves as the primary diagnostic criteria. Although the onset of the disease usually affects specific regions, such as upper or lower limbs and respiratory or bulbar areas, it progressively weakens areas of the body, leading to global muscle weakness. The terminal phase of the disease is characterized by respiratory dysfunction. Understanding the relationship between upper and lower motor neuron dysfunction is crucial for unraveling ALS pathogenesis. I will spend some time comparing the normal physiology of the motor neurons to the pathology process that occurs in ALS. After understanding how these processes work, I will go into the symptoms and causes of this disease. Um, Here we are. I'm going to discuss the normal physiology versus the pathophysiology of ALS. I'm going to get into the biochemical mechanisms involved in ALS and just the two types of neurons that they affect, which is the upper motor neurons and the lower motor neurons. In the case of ALS, two types of neurons are involved. The upper motor neurons originating from the brain's motor cortex and the corresponding lower motor neurons that extend into the brain and spinal cord, which eventually connect to the skeletal muscle. When these neurons die, we lose control over our skeletal muscle, leading to symptoms of ALS. The biochemical structure of is going to involve the structure of inclusion bodies. Inclusion bodies are abnormal aggregates of specific proteins. The three most commonly observed in ALS are TDP43, SOD1, and FUS. In looking at the normal physiology of motor neurons in the body, we have genes that encode a protein. Those genes have specific sequences of nucleotides, and those nucleotides have particular sequences of amino acids. If the protein was healthy and non-mutant, the gene is healthy and non-mutant. But what happens is in ALS, there's a genetic anomaly when encoding one of these proteins. Then in this instance, the gene sequence and protein changes. Whenever the structure changes, you also have changes in function. When this occurs, these proteins misfold, so several misfolded proteins form, and all of these proteins stick together to form aggregates. Sometimes they're called prions, which can move from one cell to the other. Looking at this diagram, it shows the motor neuron, and then it shows these proteins. And what happens is, as you can see right here in the yellow, these protein aggregates is what happens, and they also are called prions. In a normal motor neuron function, this would not happen. They would be normal proteins, but what happens is, like, these were the normal proteins, but with this, the protein aggregates, they all clump together. And when they clump together, it disturbs the structure of what's happening within the cells, and it also will disturb the function of what is supposed to happen. So sometimes, as I said, these are called prions, which can move from one cell to another, infecting multiple cells. So the proteins, these prions can actually move from one cell to the other. And this anomaly, when they're in the cells, what happens is they will cause disturbance, and these aggregates will damage cells. So, hold on 1 second, I'm sorry. So when this occurs, these proteins will misfold. Misfolded proteins form, and all of these proteins stick together to form aggregations. Sometimes they are called prions, like I said. A genetic component or environmental factor could contribute to the gene mutation, which we'll get into later. These inclusion bodies, or aggregations of misfolded proteins, accumulate in the cell's cytoplasm of the motor neuron. And this causes cell death. Looking at the diagram here, we have a motor neuron that is in blue, like I said, which is the postsynaptic neuron. And to the left of this motor neuron is the end of a neuron called the presynaptic, which is right here. In a normal healthy cell, the presynaptic neuron releases neurotransmitters. And in case we were looking at glutamate, glutamate then binds to the cell on the postsynaptic neuron, and will inhibit some sort of like response. The glutamine does not stay in that postsynaptic neuron. The glutamine is removed from the cell and will, in this astrocyte, which is part of the immune system, will take up the glutamate and degrade it. In order to get from the synapse to the cytoplasm, the glutamate needs a protein transporter. What happens is these protein transporters have a mutation. And if this protein transporter has a mutation, then the protein transporter cannot transport glutamine, usually to the astrocyte. So there's an accumulation of glutamate just all around these cells. And so there will be abnormal high levels of glutamine binding these glutamine binding receptors. In a normal physiology, glutamine binds to the receptors and it triggers the opening of calcium channels. And calcium will rush into the cytoplasm of the postsynaptic neuron. When there are excessive amounts of calcium influx into the motor neuron, what happens is this causes cytotoxicity and the cells die. So when we have this mutating protein transporter, this can lead to what they call is neuronal excitotoxicity. This is actually a key component to ALS. This mechanism doesn't involve prion proteins. However, other mechanisms do. These mutant protein aggregations discussed earlier bind to prions, which are right here, and they can infect other cells. So you have these prions that just keep moving in and out of cells, and what happens is they're killing all of these motor neurons in the brain. So the yellow circle, which is supposed to be the protein, what happens is you end up with multiple let's say we'll take one of the aggregates, SOD1 proteins that are folded, and aggregate with another misfolded SOD1 protein. This also could have happened to the FUS protein as well. So basically these prions are inside of the motor neuron, and it causes this oxidative stress and causes all sorts of issues, eventually killing the motor neurons. So once the motor neuron is dead, it leaks its contents out of the cell, and then the prion escapes, and it affects other cells. This explains why ALS can start in a focal area of the nervous system and spread to different parts of the brain. The other function of prions is that they can activate these glia cells, which is another part of the immune system, which changes the metabolism of the microglia. And these microglia release noxious chemicals, initiating an inflammatory response. Then what happens is the neuroaxon gets attacked by these chemicals, which leads to death of the neuron. In the same way these prions can attack astrocytes, they will also release noxious chemicals, which activate the inflammatory response and also damage motor neurons. So explaining this process might be a little bit in depth, but if you look to the next slide that I have, you can see the normal spinal motor neuron, which looks normal in size. It's connected to a neuromuscular junction and a normal muscle. And then you're going to look at this injury that's happened that I described, where there's sclerosis going on. By examining this picture, you can compare a typical nerve cell and then undergo the processes that I described. The outcome is a sclerotic nerve cell that is insufficient in producing an action potential, leading to a weakened skeletal muscle contraction. So as you can see, there's this synaptic failure from the sclerosis due to all of these processes. And what happens is you get an atrophied muscle. As the disease in ALS, this weakness is as a common symptom due to the presence of sclerotic motor neurons. As the disease keeps, progressing, the neurons will eventually perish, resulting in paralysis as the muscles become incapable of functioning. The symptoms experienced are related to the motor neurons affected, whether upper or lower. Like I said earlier, they described it as first, it might start in whether it's the lower or the upper extremities, and as all of these processes occur, it could be a focal. They could have focal symptoms of wherever the neurons were damaged, and then as these processes continue to happen, it can. That's why progression occurs, and different areas of the body are affected. Symptoms of ALS. The symptoms of ALS vary from person to person. Symptoms depend on the nerve cell that is affected, like I said. ALS generally begins with muscle weakness and spreads and gets worse over time. Some motor function that might happen early on: trouble walking or doing usual activities, tripping and falling, weakness in the legs, feet, or ankles, muscle cramps and twitching in arms, hand weakness or clumsiness. I know with my stepdad, he had this really, he just started getting his hand was bothering him, and he had a lot of twitching and weakness, and unfortunately it was just there. A lot of the symptoms are very vague, and to kind of pinpoint what is actually going on, it's just so difficult. Slurred speech or trouble swallowing. There's definitely an aspiration risk when swallowing is difficult. Muscles of the diaphragm weaken, often leading to paralysis, causing death. Sometimes it can affect it can affect behavior, untimely crying or laughing, thinking, or behavioral changes associated with. It's actually been linked to frontal temporal dementia in the last 5 to 10 years. They have been noticing links to this with ALS. Etiology of ALS and risk factors. 10% of people with ALS are due to a genetic reason. If a parent has ALS, their offspring has a 50% chance of inheriting the gene. Often you'll see people that have genetic components will probably be diagnosed a lot earlier in life, and this is pretty rare. ALS is most common between the ages of 60 to 85. However, there is a genetic component and may be seen earlier in life. Before the age of 65, slightly more men than women develop ALS. Environmental factors. Smoking increases the risk of developing ALS. Women after menopause who smoke are at higher risk. And they have also linked people with ALS to people that served in the military are at higher risk. It might be included to exposure to certain metals or chemicals, viral infections, or just intense exertion. So diagnosis of ALS. So as I said, ALS is very patient specific. They have every person has a different course and different kinds of symptoms. They're vague and misdiagnosed for months and sometimes even years. I know when my stepdad was having all these issues, it was just kind of going through all these tests and motions, and he even had hand surgery, and it was just very difficult because we just didn't know what was wrong. And I do actually follow a Facebook page that I just it was a ALS support page where patients and family members kind of go about and tell their experience of what happened when they were diagnosed. And a lot of people did describe that, they had this for 5 years, or they had this for even 8 years. And, doctors were saying, I don't know what's wrong, and getting tests and things weren't coming back. And it's just very difficult to diagnose. So the Gold Coast criteria is an instrumental in facilitating early diagnosis. A diagnosis of ALS is made when patients exhibit documented normal function, followed by a history of progressive motor impairment during clinical evaluation. Patients must have upper and lower motor neuron impairment in at least one body region: bulbar, thoracic, cervical, or lumbosacral. In addition to these diagnostic criteria, other tests must be done to rule out their disease. EMG is a needle that is inserted into the skin and muscles. The test records the electrical activity of the muscles when they contract and are at rest. This can identify if there is any issue with the muscles and nerves. Nerve conduction study. This test measures your nerve's ability to send impulses to muscles in different body areas. This test can determine if there's nerve damage. MRI results in most ALS patients are normal early on in diagnosis. MRI can reveal any spinal cord tumors, herniated discs, or other conditions that may be cause of the symptoms. Sometimes high resolution cameras can detect ALS changes. Also, blood and urine tests. Blood and urine samples may eliminate other possible causes of symptoms. Serum neurofilament light levels in the blood are usually high in people with ALS. This test can make a diagnosis early in the disease state. Lumbar puncture. Spinal fluid is removed using a small needle inserted between the two bones of the lower back. CSF is typically expected in ALS, but may rule out any other causes of symptoms. Actually, this stands out as a pivotal source of remnants from the neuroaxon damage. However, as the disease progression occurs, this procedure may not be feasible just because of breathing and mobility issues. Muscle biopsy. ALS can often be confused with muscle diseases. Healthcare providers may recommend undergoing a biopsy to rule out any other causes. Nerve biopsy, ALS can be confused with a nerve disease, and nerve biopsy may rule out any other causes. So as you can see, like, there's so many tests that can be done, but most of the tests just kind of rule out any other causes of this. So that could kind of explain why it takes so many months and years to kind of identify this disease when it's happening in someone. So clinical course and complications. There's no clear clinical course in ALS. The disease presents itself differently in everyone. It is believed that the involvement of the damaged motor neurons is the primary cause of weakness. Some patients may experience weakness in their upper extremities first, while others may experience weakness in their lower extremities. But some complications that may arise as the disease progresses. Breathing problems. ALS leads to muscles of the diaphragm weakening and leads to difficulty breathing. These symptoms usually occur late in the disease state but can present themselves early on if they have bulbar involvement. ALS breathing issues manifest first as shortness of breath during physical activities, and then progression occurs. Speaking problems. Most people with ALS develop weakness in the muscles used for speech. This starts with slower speech and the occasional slurring of words, and as the disease progresses, it becomes harder to speak. It's typically seen when the when the parts of the brain move the muscles that move the lips, tongue, soft palate, jaw, and vocal cords. Eating problems and malnutrition. Swallowing involves the tongue, lips, jaw, and throat. Without these muscles working together, swallowing can become difficult. Food and liquid could go down the wrong pipe and into the respiratory system, causing aspiration pneumonias. Another complication would be dementia. Up to 50% of ALS patients may experience cognitive or behavioral impairment, with up to 20% meeting the criteria for dementia syndrome. Typically resembles the symptoms of frontal temporal dementia. ALS can cause cognitive and behavioral impairment, particularly in executive function. Executive function impairments can reflect disturbances in reasoning, sequencing, ordering, regulating emotions, and a person's ability to be self-aware. This can result in abnormal behavior such as pacing, repetition, fixation, anxiety, agitation. Urinary urgency and frequency are common in ALS patients because of the muscle weakness. Also, constipation can be expected in ALS as well because the muscles of the bowel weaken and normal bowel function can be disturbed. Loss of mobility and proper nutrition can cause altered patterns as well. So those are some of the complications. So nursing interventions for these complications and for ALS. Impaired breathing due to ALS. Patients' shortness of breath during exertion should be managed by taking breaks in between activities to rest and catch their breath. Breathing exercises can help fully expand the lungs by taking 5 to 10 deep breaths with short rest in between several times each day. Patients may need a mask ventilator to breathe at night. Laying flat at night is often difficult for these patients and causes difficulty breathing. Elevating the head of the bed with a hospital bed or even with stacking pillows under their head, neck, and back is helpful. Coughing also may be difficult, and exercises like breathe stacking and huffing can help. Cough assist devices may help, pushing more air into the lungs and helping pull back air back to simulate a deep cough. Mechanical ventilators can assist much of the workload when breathing itself becomes problematic. They have these NIPPV ventilators, which are the preferred choice in this disease. It's a non-invasive positive pressure ventilation machine that delivers air through a nasal or face mask. These machines are portable and can be used as needed. Tracheostomies ventilators can be an option in advanced ALS. This could be planned or an emergency procedure when you no longer can breathe on your own. Impaired speech. Patients should see a speech pathologist early on, have them measure their speech rate, and have them assisted in determining timely interventions. Message and voice banking can be done so that your voice can be used in speech generating devices or text to speech apps. Impaired swallowing, take smaller bites of food and smaller sips of liquid. Swallow a few times to ensure the food is all cleared from your throat. Doing the chin tuck, which is tilting the chin downward, can prevent food from going down the wrong way. When eating dry foods and moistening the foods. If solid foods become difficult, you may switch to pureed foods or soft foods like pudding or mashed potatoes. If swallowing food and maintaining nutrition is impossible, a feeding tube could be an option. Impaired cognitive status due to ALS related to dementia. Use simple tools for communication and straightforward language. Supervise eating closely. May have difficulty following instructions. Assessing the patient's ability to make care decisions. Caregiver involvement may be appropriate if cognitive issues are present. Ensure caregivers have support because loved ones' behaviors like this and everything that's happening, the progression of the disease is pretty, it's just extremely stressful for family members, and to see someone that you love just progressively get worse is really just a very difficult thing. Impaired bowel and bladder interventions. Encourage the patient to record bowel movements daily. Encourage daily fluid intake of 2.5 liters. Contradicted obviously if swallowing is totally impaired. Educate and stress the importance of fiber. Use stool softeners. Miralax or Metamucil are often recommended. Laxatives should not be used on a regular basis, but may be needed when mobility decreases, and it could be required. Ineffective coping due to ALS. Informing patients about their illness, tests, and expected outcomes puts them in control and reduces stress. Encourage the patient to express their feelings and process emotions related to their life-changing diagnosis. Provide information on available counseling services. Encourage discussion with their support systems about end-of-life wishes. Offering the patient choices and including them in their treatment decision empowers them to take control and play an active role in their care. Encourage the patient to verbalize feelings and process emotions related to life-changing diagnosis. Providing counseling services. This is very important. Encourage the patient to discuss their wishes with their support systems when the disease progresses. Encourage the patient to continue to perform all their ADLs, and as long as they can physically manage them, encourage them to do that. This is an important key aspect, just because I know they say to encourage with a progressive disease, you should be early on discussing what your wishes are, because you don't want to be in a situation where you're doing that in a life-threatening or crisis that's occurring. Lastly, there's medications. There are currently 4 medications that the FDA has approved for the management of ALS. While none of these drugs can completely halt the progression of the disease, they have been shown to extend life. The 4 drugs include rilocitol, edaravone, PB-Terso, and tofersen. Each of these drugs targets different aspects of the disease, but all promise to slow the progression. It's important to note that early diagnosis and treatment can significantly impact the management of the disease. But unfortunately, as I was stated earlier, early diagnosis is often not something that happens just because symptoms are vague and can be misdiagnosed for months to years. And also, I just wanted to make note, just because my stepdad is taking a medication, but according to his specialist in Boston at Mass General, he was saying that even if if you did choose to take the medications, it is something that helps some patients, not other patients, and also that it prolongs life. They say up to like anywhere between 12 to 16 months. Expected outcomes for patients with ALS. The average life expectancy after diagnosis is 2 to 5 years, but some patients may live longer for years or decades. About 25% live 5 years or more, and up to 10% live more than 10 years. No known cure or treatment can reverse the damage caused by ALS. Goals for maintaining the disease. A multidisciplinary approach to care would benefit patients with ALS. Multidisciplinary care is essential for these patients. It involves medical practitioners in neurology, respiratory, gastroenterology, rehab, palliative care, allied healthcare professionals in physiotherapy, occupational therapy, speech and language pathology, nutrition, and social work. Health professionals in special nursing, genetic counseling, and psychology are also required. So this is a disease that requires so many specialties and so much follow-up and making sure these patients get what they need. ALS is a disease that progresses over time. Therefore, early conversation should take place between the patient, loved ones, and healthcare team about the patient's wishes. The patient will have to make many decisions and have knowledge of their options to manage their symptoms in advance and can help them, and their family members avoid being put on the spot and forced to make a difficult decision in a crisis. It is crucial to encourage the patient to express their feelings and process their emotions to this life-changing diagnosis. You can provide information on available counseling services and encourage discussions with their support system about end-of-life wishes. It's essential to follow up with the patient consistently, monitoring the progression of their disease and reporting any new symptoms. This includes increase in muscle weakness, swallowing or speech difficulties, and consideration of G2 for nutrition if swallowing is impaired. Furthermore, you should monitor for breathing difficulties. I know my stepdad has a regular pulmonary function test and ensure that the patient is fitted with an NIPPV ventilator at home. Nutrition support is also essential, ensuring the patient gets adequate nutrition, increasing protein intake, and monitoring for swallowing difficulties. It's also necessary to discuss advanced directives, code status, living will, durable power of attorney, and any other future wishes with the patient. What should the patient, health team, and nurse should do in the future to continue recovery or improvement. ALS is a disease that unfortunately cannot be cured. There's no hope for recovery or improvement. Therefore, a patient needs to be prepared for what is to come. They should be educated about their condition and have a team of doctors and nurses to discuss ALS symptoms with them. The earlier a patient prepares for the future, the better the quality of life they can expect. The healthcare team and nurses should consistently evaluate and reevaluate the patient for new symptoms and discuss coping strategies for the disease. Progressive diseases change over time and worsen, so patients should be open about discussing and reporting new symptoms to ensure they receive the necessary support and help. I also found the ALS Association to be extremely helpful. It really went over just patient-based what is to be expected. It gave links and resources to the patients, just about anything, all the symptoms, the diagnosis, what should be expected, and just tips and things that would be very helpful if someone was diagnosed with ALS. Also, another thing that was part of the ALS Association was the ALS Roundtable program. They actually initiated this in 2019, and there's a bunch of diverse stakeholders involved, which is patients, caregivers, clinicians, investigators, industry representatives, and government officials. And this group identifies challenges of ALS and recommends practical action to improve care and improvement. So basically turning discussion into action. This disease has been around for a very long time, and I think people who do, it's a very rare disease, but I think people that do have it, I'm just reading some of the support pages on the page that I have, is that people are frustrated. It's like this is happening, and they have had made innovations and things that can help patients, but people are just want, what can help, what can stop this disease. It's just really devastating for people that go through it. So I think that is definitely something, I did put that up there, is a link that would be really beneficial to look at. Just what are we doing to improve the quality of life for these people? Where is there a cure? What can we do? I mean, just everything is just so unknown, and it just can really be devastating for family members. And nextly, implications to nursing. What are some of the best practices? So ALS is a disease that requires a team of healthcare professionals, like I said. To effectively treat patients, the team must fully assess their symptoms during each visit and should suggest nursing interventions that can improve the quality of their life. A multidisciplinary approach is essential. Healthcare professional include assessing the patient's breathing, changes or difficulties, referring to a pulmonologist, having regular pulmonary function tests, using the ventilator mask, assessing patients' swallowing, speech ability, are also important. Patient education is essential, including information on symptoms to expect, the importance of reporting any changes of symptoms, and ways to increase the quality of life based on the reported symptoms. Plan of care agreed upon discharge would be based on the stage of the disease and symptoms of the patient. They need to be educated on the importance of consistently following up with their healthcare team. So ideally, patients should be reviewed every 2 to 3 months at a multidisciplinary clinic. I know there's a clinic at Mass General, which is basically for ALS and any other sort of like muscular skeletal disorder. And what happens is the patient follows up with a neurologist, who should kind of liaison everything. And they should also be closely in contact with their primary care physician, and any like home health, community health that they need. And they'll also refer them to any specialist, which would be, I've already stated all of the specialists usually they have. And then they just continually, every 2 to 3 months, follow up with their neurologist. So I do hope that you enjoyed this presentation and kind of understand the pathophysiology of ALS, why these symptoms actually occur, what can we do for these patients, and I do have 2 quiz questions. So I do have, what are inclusion bodies and how are they directly related to the pathophysiology of ALS? It does ask in the outline to describe who I would be, who these questions would be geared to, for our student. So I would pick the junior student, because they would have some knowledge about the anatomy and physiology of the body, and also of the pathophysiology concepts, and going into just like what the interventions would be and the implications. I think that would definitely be a junior level. So I do have my first quiz question, which is, what are inclusion bodies and how are they directly related to the pathophysiology of ALS? A, inclusion bodies are proteins that are normal and are directly related to the function of motor neurons. B, inclusion bodies are located in skeletal muscle tissue and eventually sclerose and lead to death, and muscle weakness. C, inclusion bodies are abnormal protein aggregates. They cause the misfolding of proteins, and the structure of these proteins changes the function, leading to sclerosis of neurons, ultimately leading to death and misfunction, muscle weakness, and eventually paralysis. D, inclusion bodies are located in the skeletal muscle and have a genetic mutation that causes the skeletal muscle to die. So the answer would be C. Inclusion bodies are abnormal proteins. They cause misfolding of proteins, and then the changing the structure leads to the sclerosis of neurons and ultimately leading to death and misfunction. Inclusion bodies, A, is not normal. They are genetic anomalies that make proteins misfold. And B, inclusion bodies are not located on the skeletal muscle. They actually originate in the brain with the motor neurons. And then those motor neurons are the ones that connect to the skeletal muscle. So that's my first question. And then my second question is, in order for ALS patients to receive the best care, what should be included in the plan of care? Check all that apply. A, it is important to not mention the future and what is to come. This could cause anxiety and depression for the patient and family members. B, a multidisciplinary team approach involves meeting every 2 to 3 months with a primary neurologist who will be in close contact with PCP and community-based care. The neurologist will coordinate visits to appropriate specialties, which are physical, occupational therapist, pulmonary, speech and swallow, and nutritionist. C, the patient should be encouraged to discuss their wishes and what they want early on regarding the quality of life. This is important because ALS is progressive and unpredictable, and patients and family members should avoid having to make these decisions during a health crisis. And D, patients should not worry about reporting changes in symptoms to multidisciplinary team members. This is expected in the disease process. So the answers are B and C. A, it is important not to mention the future and what's to come. This could cause anxiety and depression is incorrect. Although it may cause anxiety and depression, it is important for family members and patients to discuss what is to come. Disease is progressive. You don't want to be making decisions when there's a life-threatening or crisis going on. It's just not, you're not thinking clearly. It's not going to promote what the patient wants and the quality of life of patients. Also, D is wrong. Patients should not worry about reporting changes in symptoms. This is expected. Although it is expected, they do need to be reported, and doctors and nurses and team members need to be asking these questions as well. They're important. If a patient didn't mention that they were having difficulty swallowing, they could have difficulty swallowing and aspirate and cause a pneumonia. And with someone immune compromised, like a patient with ALS, that could really cause someone to be extremely sick and even cause death. So this is extremely important to be always reporting changes in symptoms. And then I do have references if anyone's interested in looking at these further. And I also did give you the round table link, which I think is extremely beneficial, just to see like what are we doing as as a whole to try to stop ALS or to try to come up with other things to cure this disease. A lot of people are suffering, and this disease has been it's been, Lou Gehrig had it in, I think it was the 40s, so 40s or 50s, and there hasn't been a ton of research. I mean, there has been research done, but no answers to the research. If you have any questions, you could email me or message me. I hope you enjoyed the video. Thank you.